Hello, everyone. I want to thank Gordon, Andrew, and the NRHA generally for organising this. It is a new initiative undertaking new geographical classifications, and getting the word out there is an important thing. It's something that government departments can be a bit slow to do sometimes. But having events like this, we appreciate, and it's a chance, and love the opportunity, the chance to take you through how we got here to the Modified Monash and how we see it going into the future. So I've been told, if I click here, yes. Okay, so first of all, I know a lot of people have seen this screen before. I will be going through a beginning of something of a standard presentation. I go around the Modified Monash, but I promise everyone who has seen it, I've got some new stuff at the end, so please stay awake. And what I intend to do is first of all go through the evolution, both what the problems we had which caused or created a need for a new way to look at remoteness classifications, and then the Modified Monash itself and some of the interesting things that we've seen come out of it, and really sort of trying to strengthen the sense that it is becoming a better tool to take a look at how people are distributed in rural Australia. So to begin with, we'll start where we were in 2008-9. I'm using the old ABS ASGCRA. I think most people would be familiar with it, based on the 2006, and I've chosen this one rather than the latest one because most departmental health programs are still using this classification. So what you have here is RA 1 to 5, as we like to call it, 0 to 4 if you're in ABS land. For major cities, and they're hard to see, but little bits of green here and there. The pink being inner regional, brown outer regional, remote, and the grey very remote. And the thing I'd like you to take a look at here, whoops, if I can get the buttons right, is that what we have is a banded picture of Australia. And the reason this occurs is because the remoteness classification system that the ABS use, and as mentioned beforehand, originally based on the SocioEconomic Index, measures any location to the distance from that location to a number of other large centres and towns. And so naturally, two nearby areas will have similar distances to nearby towns, and we end up with a very much a layered sort of look at remoteness. And we also get a sort of, evolving bands. It sort of evolves from your major cities out to the very remote. And that is exactly what the remoteness area claims to do. Remoteness, by its very name, is about distance, and as a distance measure, it's an incredible advancement as to what we had, pre-2000. The problem we got into when we started using it for health programs is that we started using a sense of remoteness as a measure of how many services you have nearby. And when you think about it, if you are 200 or 300 kilometres away from Sydney, it's not going to be so much, the number of services you're going to have nearby are going to be more dependent on what your nearby town is rather than that 100 kilometre distance to Sydney. And so the actual criticism we're getting with things like Hobart and Gundagai are both RA2. Gundagai's got around 2,000 people. Hobart's a capital of one of our states, has a hospital, full range of services. And because we're paying financial incentives on the RA basis, people naturally complain that why would you go to Gundagai if you could go to Hobart? A little worse is the fact that Cairns is RA3. Again, it is more distant from other population centres, but as a city, it's got more than 100,000 people. Again, it's got a hospital. I'm not saying it's as nice a place to live as Sydney and has this, that same metropolitan feel, but it certainly has a bigger range of services than you find in Gundagai. And that comes to the point we were saying beforehand. RA is a measure of remoteness. using it as a measure or a proxy for the number of services you have within reach isn't always the best way to take a look at it. So we move on to the Monash model. And no, not modified, this is the original Monash model. I've got Professor John Humphreys et al. There, but that includes Matthew McGrail, who I believe did a lot of the underpinning and the modelling that went into the paper. And I'm sure Matthew's going to stand up and correct me as I go through this. But basically, the original paper used the Mabel survey, it's a longitudinal survey on medical officers, looking at their life and work patterns, and looked at how 6 key workforce indicators relate to both town size and the RA classification. And these sort of indicators are ones that are well published as being key to how nice it is for a GP to work somewhere. I got this, yeah? 2 of them, partner employment and schooling, have nothing to do with medical work. It's about what's in the area around you. The other ones, while specific to the sort of things that a GP encounter, nonetheless, if you think of them as being encapsulated by what happens with different sizes of professional networks, you get a sense of why this actually has much broader use than just GPs. And obviously, the more GPs you have, the less hours you're going to have to work, easier to get time off and so forth. And of course, the bigger town size you are, the more likely you're to have a large professional network around you. And so when the Monash classification came out, these 6 categories were considered to be distinct, short list. If you actually read the paper, there's more breakups that are of statistical significance. But in the sense of making it usable, we had these 6 classifications suggested by the paper. So RA1 being your major cities, that hasn't changed. For 2, 3 and 4, we're looking at all of rural Australia and breaking it up into town size, 5 to 15, 15 to 50, and greater than 50,000. And we only differentiate in RA when you have populations less than 5,000. So we have 2 and 3 is 5, and 4 and 5 is 6. And these were all verified by the correlations with the actual workforce indicators, and all, reasonably established by good solid evidence. Now, at the time the Monash came out, it was coincided when the Senate was having their inquiry into factors affecting the supply of health services and medical professionals in rural areas 2012. And I spell it out because Fiona Nash was actually a member of this inquiry, and I remember her actually taking particular interest in the way that the Department of Health was using the remoteness classification. And she brought up the same issues that we went through beforehand, that we don't look at how many people are nearby when we use RA. RA is essentially a distance measure. The inquiry report from that committee noted that they were impressed by the Monash model. They didn't actually say Department of Health pick it up, but they did say the Department of Health should be looking at something like this, taking into a number of factors, nearby factors, as well as simply the RA measure. And naturally enough, that then led into a departmental independent review of Australian government health workforce programs, which was conducted shortly afterwards, led by Jenny Mason, and I believe a number of people here would have been part of those stakeholder consultations, as many issues were looked at, including the department's use of geographical classifications. Through those consultations, we did have some concerns being raised. And the principal ones were that there seems to still be a tyranny of distance. Mount Isa is in the same classification of Coffs Harbour. That's a sort of random pull-up of names. But if you know Mount Isa, you know that it does have difficulty attracting GPs. Alice Springs is another one that does. And just generally, we went and took a look at the MBS billing in similar-sized towns across different RAs, and we still saw that RA4 and 5 had reduced billing. And at the time, we had incentive payments to encourage GPs to work there. So this was in the face of those incentive payments. We were still seeing much less MBS billing occurring in the RA4 and 5 towns. So in a sense, that distance became a dominating factor, not on those key workforce indicators, but in other ways. And what that did is it led us to the development of the Modified Monash Model. So within the actual independent review, it was recommended that we keep RA4 and 5 as separate categories, and that was a result of the stakeholder consultation. Once we had the Modified Monash, both fairly soon after the actual review itself, and then it picked up a bit again after the consultation picked up again afterwards, after Minister Nash announced the Modified Monash, we went and looked at some of the implementation issues. And to give you a feel for that, our best indicator of what a town is, and especially when we're looking at small towns, less than 5,000 people have to be included, is the ABS's urban centres and localities layer. And it identifies communities across Australia. However, because of the rules that the ABS use, and good ones for very good reasons, you have Albury-Wodonga as 2 separate towns, because one half is in New South Wales, the other half is in Victoria. Yet functionally we think of them as the same sort of service area. And the other issue we were getting is that quite often you would have a small community which would be definitely separate from a big large city nearby, but nonetheless like 5 kilometres difference, and people in there would travel to work into the larger town, often see doctors in the larger town on their lunch break. Basically, and I think there's been a lot of research into geospatial analysis that has shown this, is that larger towns throw a functional shadow over their nearby areas. And that's what we're trying to pick up by having a sense of buffer zones around the large towns. And when we went to the consultation around this, the main point of the consultation was to make sure that the buffer zones met expectations about what the functional zone was. So we broadly talked with a lot of stakeholders from rural Australia, making sure that they did make sense, making sure their size was right, making sure that the way we were working with towns was correct, and that people were happy that we hadn't inadvertently done something which was going to cause, again, problems like we had with the original RA rollout. And so at the end of all those consultations, we come to the Modified Monash Model. As I said, very similar to the original Monash Model, except for RA4 and 5. There's more categories on the next page, so there are full 7, don't worry. Still MM1 areas in RA1. MM2 are areas in RA2 and 3 that are in or within 20 kilometres road distance of town with 50,000 plus people. We're very careful not to specify that that town had to be in any particular remoteness area. The example I like to use is Picton, which is RA2, which is right outside of Sydney, but within that 20 kilometre distance. And we thought Picton should be treated the same way as a town within 20 kilometres of Hobart. And that is classed as Modified Monash 2. As you go down, basically areas that haven't already been classified are then classified according to the population size of their nearest city. So 3 is 15 to 50,000 again, but we have a layered buffer. Instead of 20 kilometres, it goes down to 15. And for 4, 5,000 to 15, and it's a 10 kilometre buffer. And note that we're only talking RA2 and 3. And so then our last 3 categories is almost everything else. We have MM5, so that's going to be all those areas in RA2 and 3 that aren't near a big city. MM6 is basically RA4, MM7 is RA5. We did make a decision, and this was again following after stakeholder consultations, which was that because of the way the ARIA formula uses ferries, you could often get quite strange results where having, the example I use is Bathurst Island, the town of Newey, which has changed its name, I know, but I'm not very good at pronouncing it, and that's my failing, has a ferry that goes once, twice a day from Newey to Darwin. It's a 50-kilometre trip. If you hop on and go on your shopping list, you're in a hell of a lot of trouble. But because of that, ferry is considered RA4. So listening to the stakeholders, we considered it to be MM7 and equivalent to RA5. Before I go and show all the fascinating maps, and even though I've got a whole heap of them, I don't go through them all. I just can't take them out whenever I do the presentation. But the way to think about the Modified Monash, because we keep one the same, we keep RA4 as its own classification, we keep RA5 as its own classification. The way to think about Modified Monash is to think of combining RA2 and 3 and splitting it out again by town size. And that's going to be a thing for the rest of what we look through, and seeing how that actually gives us a better measure for many purposes in looking at rural Australia. So first of all, some of the effects of it. As we go through these maps, on the left-hand side is the RA 2006 version. Sorry about the names. I think you can see them if you look closely. And on the right-hand side is the Modified Monash. So let me point out a few nice little key features here. We have Parkes, Forbes, and Cowra. The thing here, then, the reason we like showing this one is Forbes is RA3, Cowra is RA2. They both have very similar populations and very similar cities. But because Cowra, by road distance, is slightly closer to Orange, slightly closer to some of the bigger cities because of the road, it does fall into the RA2 classification. Whereas when we go to the Modified Monash, Parkes, Cowra and Forbes are all considered Modified Monash 4. Again, basically saying that your nearby services are quite a distance away and the town you're in is between 5 and 15,000 people. We have Orange, no longer the same classification as Cowra, it's MM3 there. And then you have this big stretch of green in between. And these places, you know, it is a trip to going to either of those cities. And you can actually see, well, you may be able to see that there are little red dots in many of these towns, which is evidence of Medicare billing. These towns do have doctors. People are going to those doctors rather than going to the city. And it's those doctors we want to support more than, dare I say it, the ones who are living in Orange, where they've got a, you know, I think they've got a hospital there, but certainly much more services. So we have the Ballarat, Stawell, Ararat issue, and this is a bit of the opposite. In the last one we saw two similar towns being split by RA. Here we have Ballarat, because of this road, RA2 extending from Ballarat to Stawell. Distance of 32 kilometres is down here on the legend bar, so we're talking more than 100 kilometres. And it's basically, that's the road that's connecting them and giving them their particular RA classification. So they have to get 100 kilometres just to get to Ballarat, and they're still in RA2, going further to any of the larger cities. Again, it's, yes, they probably have a similar remoteness to all the other larger town centres, but in Stawell, you do have a different range of services available to you. And so when we go over to the Modified Monash, we see, again, Stawell is the 4 category, Ararat, a lot of 5s here, again, 5s which actually have doctors in it. Now, I'm not sure, but I think that little dot there is Cardigan. That is actually just a couple of kilometres away from Ballarat. Whoops. And that is one of the sort of things we're keeping in mind when we're using the buffer zone, that these areas are actually of reasonable distance away from the actual Ballarat to be able to functionally say that they can access their services there. And I guess the thinking here is that if you had someone in hospital in Ballarat, these people would be able to go for a lunchtime visit. People in Stawell would not. And again, nice schools. Ballarat will have more nicer schools. People nearby will be able to use them. Once you get a certain distance away, it's just not worth the effort. You can't drop the kids off by 8:30. I've got a whole heap of these, so I think this is the last one I'll put a little focus on. And this is Cann's, and I love it because simply as a demonstration of the Modified Monash, all of this is RA3. Just one big wide swath of equivalent incentives. And that is the way, when you have a remoteness system, speaking from a governmental perspective, and I should have said earlier, I'm in the rural distribution section of the Rural Access Branch of Health Workforce Division, so we look at these things a lot. When you're crafting a policy, you have to use some objective and known parameters. And when we were only restricted to RA, we didn't really have the tools to be able to actually not give them all the same eligibility, all the same benefits, all the same access or resources. But once we moved to Modified Monash, we have Cairns as a MM2 town, whereas these, and it's Mareeba and Atherton, again considered MM4. I was happy to hear when I showed my boss, who just started a job a few months ago, she actually came from this area, and she said, I think it was Mareeba, you didn't wear shoes, but you put them on when you went into Cairns when you're growing up. So it does pick up differences, and that's the thing we've seen when we go through with stakeholders, is that these towns have a different nature. People tend to just shop locally and use the local services, and as a result, they do tend to have less services, even though sort of Cairns is maybe 40, 50 kilometres down the road. So as you can see, I can go on forever. I always like this one because there's this little patch of, one MM4 between MM3 and MM2. All of Gippsland is considered MM5, small towns, as opposed to this big swath of RA2 that was there beforehand. Again, RA2 being driven by this road, which we've now sort of broken up again into local town size. Bendigo and always another good example. And as you go through these, you just see that on one side you have these broad bands, on the other side you have a much more discrete, directed geography in which you can look at where people are. And finally, we always have to do this one because it's Townsville and Charters Tower. We got a lot of letters to the Minister about that. Same classification, under Modified Monash, we get to separate them out a bit. One thing I'll say about the Modified Monash, we do, as you saw, stick to the ABS remoteness area classification as a base, except for the island issue. We use ASGS for it, not ASGC, and we plan to update after every update of the remoteness areas from the ABS. But you do get these little SA1 related issues of a little pokey MM7 coming right up to the corner of Charters Tower, and it's because it's basically an empty, large area which doesn't have enough people to break up more. So going through all of that, it's, I hope you've been able to see that there is a much more distinctness around the Modified Monash and the way it looks at towns. So I thought it'd be worthwhile to actually also take a look at some of the statistics around this. And again, why we're seeing it as being a very useful thing. And for those who have fallen asleep, this is the new part. So here we're looking at the Australian population by RA. I think a lot of people will be familiar with this. We've got 70% of the population in RA1, about 1% when you round up in RA4 and 5. RA2 has around 18%, RA3 is 9%, and I know this because I was looking at the figures last night. And I guess the thing that you get away from this is, yes, 70% 30, then we have the RA2 double the size of RA3, which makes sense because it's distance to population centres, and RA2 will have more population centres in it. And it sort of follows that, that's 70-30, and this is sort of 66-33, so a bit of a powerful distribution pattern. When we get to Modified Monash, we get an extremely different picture. We still have MM1, RA1, 6, 7 stay the same as they were. But now we see that the breakups of the population between the 4 categories that have replaced RA2 and 3 are looking a lot more even. And in fact, I can confirm that MM2, the bigger town's 50,000, there's 14 of them, contains about the same amount of population, only 400,000 more than the ones in MM5, people living in less than 5,000. And if you stop and think about that, similar number of people, but here they're all clustered. And in MM5, they're distributed across all of Australia. And think about the challenge that that presents when you think about trying to provide equity of health services to people. Because here we can just place a super clinic. Here we have to start getting into innovative models of delivery. You have to have, in truth, the sort of things that you'll do in MM5 are going to be similar to the things you want to do in MM6 and 7, taking care of small population centres distributed across Australia. And you're not just taking care of a few people, you're actually taking care of, when you put it all together, more people here than you would be by just looking at what you're doing in MM2. The other great thing about this is this evenness of distribution. And yes, it does fall a bit, but we don't have that sort of one twice the other, except for MM4, it's about half of MM2. But again, it starts us driving of stops us looking at simply dollars per person and looking at, well, if we did dollars per person, that all gets, broadly similar amounts. But that money will go won't go as far. Those resources need to be stretched in a different way when you look at these smaller classifications. And it's that sort of honing effect that we like about the Modified Monash. It sort of brings us to, starts us thinking that if we do really want equity of access, then we have to be thinking about what's happening in these smaller towns. Otherwise, we're leaving off a significant portion of the rural population. So looking at growth in FWE by RA, this one might be a bit familiar. We normally put this one up to show that our health policies have been working. So there's typically more growth in RA 2 to 5 than overall in the number of GPs in rural Australia. 5 is working off a low base, so that's a bit misleading. But worth keeping in mind, RA 2 and 3, they have very similar growth patterns. Break it out by Modified Monash, and suddenly you see a much more differentiated fall in the growth of doctors. Again, here we said that this is a bit misleading because of the difference in, it's working off a low base, it's a small population, but we know MM5 has about the same number of people in it as MM2. Previously we went out to distinguish the two of them. And so now this difference is, percentage point for percentage point, talking about the number of people who are going to have less access to healthcare. And again, sort of honing the mind in on the fact that we need to sort of treat the way we resource and deliver health services and basically services to the different Modified Monash categories. Percent of people in the lowest 2 CIFA quintiles. So for those who aren't familiar with it, CIFA is a SocioEconomic Index for areas. It's area-based, not population-based, so it's not quite true to say, but it's close to say that a given area would have a normal socioeconomic profile if 40%, if this bar reached to the 40% mark. So under RA1, they tend to have the less people living in the lower 2 CIFA quintiles, worse off. RA2 to 3, 4, 5 or greater. 2 and 3, you're looking at about 5 percentage points difference there in between the number of people living in the low CIFA areas. And when you cast this over to Modified Monash, again, we get a much more differentiated picture. We see that the people living in the big towns, yes, they're higher, but they're actually close to where the national average should be and much closer to MM1. You're talking less than 10%, where here you're talking almost a 20% difference in the proportion of your population living in low CIFA areas. And I picked the lowest 2 quintiles because those are the below average ones. The next one is average and the next 2 are less well off. And I've been picking that for a while now, so it's more habit than anything else. And we can, again, focus our attention. We also pick up this nice little fact that 5 is actually better off, than 4 is. Still worse than 2. And again, because we're talking equal number of people, we are talking about a percentage point difference really does represent an equivalent number of people. Well, not quite, but close enough. So just something we'll get to at the end. The reason I can do this is that the ABS produces these figures at the SO1 level. And we'll talk, say a few seconds about this later, but basically the Modified Monash allocates a Modified Monash category to each SO1. So there is some matching with the ABS geographies, which allows us to do all of these. So the population-driven one was driven off population figures that we purchased from the ABS on the 2014 population at the SO1 level. So the fact that there is that matching does allow us to extend the ABS measures where they do go down to SO1 into a Modified Monash look. So now that we've looked at workforce, we've looked at socioeconomic conditions, we've looked at sheer population, I thought it would be wrong of me not to try and at least do one health outcome one. This is drawn from the ABS census, and if you have Table Builder Pro, you can get answers to this question. People who needed assistance with their core activities. And so the percentage that we're looking at there is the people who said they needed assistance compared to the total number of people that were recorded for that question. Again, because the ABS allow it, we're allowed to get that at the SO1 level, and we can aggregate by MMM. It is based on the census, and census has the usual issues of non-replies in some areas and self-perception as to whether you need care or not. And so when you take a look at it, so the number per 1,000, because we're talking small numbers, I just wanted to sort of not have decimal points on the x-axis. Again, we find, and I do find it curious, and I don't know how much this is to do with people's perception of what assistance they need compared to actual levels of assistance and something that needs to be thrown in. But you do find RA1, that's really 4%, 2, 3 are higher than it, but again, you see them being very similar. 4 and 5 actually much lower, and you do get into a position of saying, are people moving to major cities if they've got a problem? Or do they actually see the limitations in a different way in more remote areas? But putting that aside, when we break it out by Modified Monash, we get a much different picture. We find that the people in major cities, in the bigger cities in RA2 and 3, actually see there are limitations very much in line with Modified Monash 1. You have 3, 4 and 5, again grouped nicely together, but significantly different from what's happening in MM1 and 2, and of course 6 and 7 stay where they were. And again, 5 looks like, as with CFA, just a little bit better off than the other classifications, which sort of may be a big point for going into rural Australia and moving there. So I guess that's the end of the formal presentation, or what I could put on slides. I think I'll end with saying a little bit about the fact of what we are doing in the department regarding this at the moment. Now, we have a number of programs that are looking at the Modified Monash. We've already mentioned the incentive payments, GP rule incentive payments. We also have the dental relocation scheme has been announced to move to scale payments according to which Modified Monash you're going to. Bonded medical placements can students who have had a bonded medical place can return their service of obligations to Modified Monash 4 to 7. And we've also recently announced a combination of our locum programs, and we're seeking applications now to deliver that, what we're calling the Rural Locum Assistance Program, or Rural LAP. And that one will prioritise locums when we get over subscription by Modified Monash. And going forward, we sort of see uses of Modified Monash falling into sort of 2 different categories. One as a sheer eligibility for incentives or for payments, like the rural incentive payment, or moving between areas. And again, where we feel a need that we have to direct resources more to those smaller remote communities, the ones that are falling into Modified Monash 5. And the other way that you may see it rise, sort of come into play, is when we talk about sort of bigger resource allocation questions. And the approach the department takes with these is to basically start weighting people by their Modified Monash category, their CEFA category, their Indigenous category, and using that to prioritise areas. And the word areas can be SA3s or towns, it depends on what you're looking at, or where to place grants. You prioritise according to your weighted population. And again, having RA2 and 3 as it was meant that those big towns were combined with the small towns in the RA classifications, and it was very hard to get into a position where you could properly acknowledge that delivering services to 5 towns with 8,000 population in MM5 is a lot harder than providing services to one town of 8,000 people in MM4. And so then, now that we have this way of breaking it up, I think will feed into enabling that sort of low density distribution areas to be weighted higher up in terms of what it takes to get services out there and prioritise higher up the list. And the fact that MM5 has a similar population to MM2 is only just a bonus in actually making sure that that weighted population floats up quicker. And on terms of just looking at my list of things I was meant to go through, current available resources. So we have a Dr. Connect website. If you go to the Dr. Connect website, you'll find 2 things related to Modified Monash. One will be a locator where you can type in a location and see which Modified Monash category it's in. The other thing we have, and this is for I think people such as yourself who may want to get into more looking at how your distribution of services, your distribution of population fits into this look at the world. We have the Esri shapefile, and we also have an allocation table from the Modified Monash SA1. And that part is in our rural health reform webpage. You click on Modified Monash, and at the very last question, it has a scary, I'm a technical user of information. Where can I get more? We're also fairly conscious that not everyone loves doing concordances and correspondences. I think Martin, when he gets up here, will talk a bit about that from the ABS point of view. But just so people know, is that we are getting more conscious that we'll probably want to float up a postcode to Modified Monash and some sort of ABS geography to Modified Monash at some point in the future. Technically, if you've got a postcode layer in the Esri, you could put it together yourself, but it's not the funnest job in the world. So I think I might wrap it up there, quite significantly earlier. Yeah.
Thanks, Paul.